Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. In this episode, we're joined by Sir David Spiegelhalter, Professor of the Public Understanding of Risk at Cambridge University. We talk about how best to communicate risk in medicine and the wider public sphere, and how individuals should see risk differently from governments. How can our perceptions of risk change over time? And finally, why some of the risks that we hear about in the media shouldn't always be taken at face value. David, welcome on the Pager podcast. Thanks for joining me today.
Yeah, great to be here.
I was just wondering, we're sitting here in the Centre for Mathematical Sciences, and I know you've had a huge involvement with the Winton Centre. Could you just tell me a bit about the work that you do there?
Yeah, the Winton Centre is a curious beast, really. It's called the Winton Centre for Risk and Evidence Communication, philanthropically funded by David Harding, a hedge fund manager, very generous, which enables quite a large team. It's about 11 of us now, to work on all aspects of trying to communicate what you might call quantitative evidence, where the numbers, statistics, risks, uncertainty, and so on. And it's in the maths department, except I'm the only actual sort of statistician, mathematician. So it's quite slightly bizarre that in the maths department we've got a team of, I think we've got 4 or 5 psychologists, we've got communication, ex-BBC communication people, web designers, we've got an actor, we've got all these people, film expertise, and we're sitting in the maths department, which gives it a good brand, in fact, even if we're not doing any serious mathematics.
I guess this comes down to the point that it's not just the numbers, it's what you do with them that counts.
Well, it's what I've really learned is that, I'm a statistician. I've always worked in statistical units and around sort of mathematically trained people. But over the last 10 years or so, I've changed completely and spent all my time with social scientists now. So I spend all my time with we often also have a scientific training, but they specialised in communication, psychologists who specialise in evaluating messages, and actually storytellers, people who are good at constructing gripping narratives in order to put over a point. And I've learned, it's given me great humility, because I realise, as I always say in my book and everywhere else, everyone says this: numbers do not speak for themselves. We imbue them with meaning. The story, the message is absolutely important.
And indeed, I had a look on the Winton Centre's website, and at the top of it, in big bold words, are to inform and not to persuade.
Oh, yeah. No, this is a constant struggle, really, because that's what our sort of strap line. We want to inform people, and at its best, the idea is that we can, by providing information and evidence in a clear, acceptable form, we can empower people to make better decisions. Now, that people, we could mean patients, we could mean policymakers, we could mean, ordinary public judging the proposals, claims being made about particular policies. We could talk about lawyers and judges, we could talk about journalists, all of these people we work with. And the idea is that to counter the sort of flood of misinformation and fake claims and things like that, which people are surrounded with, by providing what we feel, telling it how it is in a good, balanced way, without an agenda. We do not want to influence behaviour. We do not want to make people do anything. We keep away from that. We just want people to make better decisions and feel happier with the way in which that decision was made. Even if it turns out wrong in the end, at least they feel it was done properly. But and the other end of that, of course, people who want to change their behaviour, who want you to drink less or exercise more, and all these are worthy objectives. Well, we don't do that. That's not what we do. But there is, of course, a grey area. This is not black or white, because we realise we are trying to persuade people to take notice. We'd like people to take greater, have more influence over the decisions that they make. We are trying to counter, this is all a bit too complicated, what do you think I should do? Just people just handing over their responsibility of the decision to others. And so things might be done to them that actually they feel later on they might regret. So we do want to persuade people to engage with decision, to empower them to engage in that way. We also, I suppose, want to persuade people when they're faced with when actually they believe things that just aren't true. Whether it's about vaccines or something like that, we do want to persuade people that there is some bad evidence out there, people are saying things that are just not true. So we want to preempt misunderstanding. So it's not a black and white thing at all, but we definitely want to try to be on the open end of it. But we definitely want to try to be on the informed side.
And I guess a question leading on from this is, how much is too much information?
Well, that's exactly right. The transparency in information is the worst thing you could do is just go blah. It's called fishbowl transparency, when you just dump everything on everybody, and it's overwhelming. You haven't got a clue. You imagine patients, and I'm a patient sometimes. You go onto you clicking around the web, and you say, "Oh God, it's all this stuff. You don't know what to believe. It's all in a bad for you. You don't know." It's very difficult to process that. So we curate very carefully the information that we're providing using tested formats, and it's developed in a staged way, so you can deliver at different levels. That people, you can give some information. Who do want to know, people can click down and find out more information. They can find it in different formats. They can find, if they want, where that evidence comes from. Not that many people want to, but that's fine if they want to. So there's no correct format for any of it for doing this, and you have to respond to people's needs and demands and their understanding.
So I guess transparency in this case is having perhaps all of the evidence available, but not necessarily on show.
Yeah. People should be able to find it if they want. I'm hugely influenced by the wonderful philosopher, we might come back to it, Honora O'Neill, who's a Cambridge philosopher of Kant, who's got some wonderful sound bites about what she calls intelligent transparency when it comes to data and information. She's got 4 criteria, and I think these should be emblazoned on every bit of health communication that goes on. She says all information, if you're going to be trustworthy, information, the first thing, it's got to be accessible. People have got to be able to get at it. That's easier now than it was. Because of the web, it's not just sitting around in doctors' waiting rooms or whatever. You can get at it easily. It's got to be comprehensible, and you need to test that. People have to be able to understand it, and you have to allow for low numeracy of people, and so on. So maybe different formats for that. It's got to be usable. I love this one. Usable, meaning that it's got to actually address people's concerns. It's no good talking about stuff that they don't care about. It's got to actually address their worries and their concerns, and that means you have to listen. First rule of communication: shut up and listen to what people are actually worried about, even if you think they're wrong. You have to address that and try to perhaps set them right. And the final one she's got, now you might think, well, that's enough for good communication. No, it's got to be accessible. This is this duty to provide information that if the audience wants to, they could check you're working. They're not just having to take it on your authority. I know best. Here's what, these are the facts. Because everybody says that. You can go onto some really crap vaccine website and it'll tell you the facts about any website that says the facts about vaccination. I immediately distrust. So you got to be able to provide the basis for that if people want to know. Usually they don't, but some people would, especially in Cambridge.
Well, I guess kind of an intermediate in this stage could be, I might not necessarily want to look through all the working, but I can look at an independent body who has looked through it that I trust as well. Exactly.
The crucial thing is that, and you often, actually, when a website's making a claim, you cannot tell from the website itself the reliability of that claim. You have to look at what other people have said about it. And Honora O'Neill's very clear about this as well, that trust and insight is not a matter of all this transparency. We should not have to check everything that everybody said to us. We should, we should feel that this is someone's looking at this on our behalf. I don't want to have to check up on every doctor about whether he's qualified and whether he's in the least bit competent. I assume that someone's looking at this. I don't want to check with every hospital what its mortality rate is. I assume someone's looking at this for me and doing something about it.
Indeed. It's interesting that we seem to have this kind of evolutionary tendency actually to trust people rather than distrust them. Otherwise, maybe our relationships would fall apart.
We can't cope. She makes this very clear. We couldn't function in society unless we trust. It's absolutely founded on trust. We can't go around checking absolutely everything for us, and we shouldn't have to. And of course you want to trust. I mean, one has a basic philosophy. I would say I'm fairly skeptical, but I'm not cynical. And I would rather be occasionally caught out by someone who's conning me than mistrust everybody. So I'm kind of naive, and sometimes I'm fooled, sometimes I'm conned. But I don't like it, and so I try to avoid it. But I'm not going to go around being paranoid about everybody all the time. That's very negative. We can't survive like that.
And we're going to talk, I think, a bit in this episode about risk and uncertainty, particularly in the medical sphere.
Yeah.
So I'd like to start off just by asking quickly, what do we mean by risk, then?
Well, these you can mean anything you want. If you look at, there's 87 definitions or something of risk. So I tend to use it in the sense of, being in a situation where things might turn out well or things might turn out badly. Taking every medical treatment is, in some sense, a risk. Or, people often talk about the risk only associated with downsides, things that might go wrong. And you can sometimes use the word chance for the things that might go right. So I've got a chance of winning the lottery, but a risk of getting a side effect from a drug. But that's just one way of using the language.
Or you did a risk of something not going well.
Yeah, exactly. But there is a way that I tend to use it, which comes from actually economics and social science. It was developed about a century ago by an economist called Frank Knight, and Keynes uses this as well, of a distinction between risk and uncertainty. And this is often used within many areas, and I like it. That risk is about things that we kind of understand and, in a way, known unknowns, to use Donald Rumsfeld's great phrase. One of the things we can put numbers on, things within fairly circumscribed situations where you can put, so, a lot of medicine is like this. There's a lot of reputation, a lot of data. Insurance is like this much of the time. We can put numbers, we know roughly what the chances are, and we can talk about the numbers. Uncertainty is when essentially we don't know the numbers. Or with deeper uncertainty, we don't even know what the problem is. We don't know what the options are. We don't know what the possible outcomes are. And so we tend to perhaps think of something that's going to happen quite soon or is well understood as risk. But we're talking about what will happen in the world 10 years' time. Who's going to start putting chances on this? You'd be really deluded. It's much more deeper uncertainty, or sometimes called radical uncertainty, or sometimes or whatever. Yeah.
Yeah. So uncertainty on risk in this situation.
Yeah. You can be uncertain what the risks are. And this current COVID-19 virus thing is a classic situation, I think, of this is currently an uncertainty problem rather than a risk problem, because we just don't know the parameters. We don't know quite how it might spread in Britain. We don't know the effectiveness of the interventions that are going to be made. So it means that when you're making projections about what might happen in the future over the next 6 months, there's a massive range of possibilities, up to 500,000 deaths, probably from about 5 or something, the most optimistic that somehow it's closed down. So that's quite a range, and it means that any quantification, giving any probabilities, would be pretty well, would be very ambitious, I think.
Though that doesn't necessarily stop the mainstream media from reporting statistics that have a lot of uncertainty around them, but without that.
Well, they don't even talk about the uncertainty. Of course, now what they do tend to is report the worst case scenarios. And there's a real problem that, and I've been talking about this quite a lot, is that the only numbers being bandied around at the moment are the worst case scenario, 500,000 deaths. Well, that must come out of some rough model in which we assume that absolutely nothing is done. It's just let free to infect 80% of the population, of which 1% then die. And that's the model. So it's as if we say, virus, who cares? Virus, schmarus, we're not going to do anything about it. Well, that's not going to happen. But that's the number that's being reported as the worst case scenario. So the thing that's being reported is the thing that's least likely to happen. And that's what all the headlines on, which of course might be an effective strategy to get people motivated to wash their hands and actually obey the instructions. So it might be quite good as a nudge, as a behaviour change influence. But in terms of providing information, it's awful.
Yeah, I guess particularly now, given that probably the majority of the effects of COVID-19 don't necessarily come from the virus itself infecting people, but come from people's responses to it. We hear kind of bounded around 2% of global GDP, which is an enormous value as well.
Yeah.
So panic here.
Huge economic value. And of course, the markets panic more than people do. So the stock market's going up and down, bouncing around. And it essentially is a trade-off that if you were trying to optimize, we're not going to want any deaths at all. We just close down the whole economy and everyone has to stay in their houses for weeks, for 3 weeks. weeks or something, and then that probably would close it down, and we'd end up with 5 deaths or something like that. Now, that's going to be pretty disastrous, especially if it's even the incubation time, something 11 days, you'd have to close them down, for weeks. So that's hopeless. Although China, to be honest, looks like it has nipped it in the bud by absolutely draconian responses. So there is one. But at the other end, there's Boris Johnson used this phrase, I think we might have just taken this on the chin. I think it's not ridiculous that actually, it's going to get out. We just want to mitigate it as far as we can, but it is going to happen. And again, it's best to keep in mind seasonal flu, average year, kills 6,000 people in this country, mainly old and vulnerable and frail and things like that. So, we are hit by this year after year after year of epidemics that happen. And so we got to put this in perspective. And to an extent, it is a trade-off between massive disruption. And the other thing is economically, it's not, if you said everyone's got to stay in their home for 4 weeks, that's not just economic loss. It has a massive, health benefit in terms of people's mentality and fitness and all that as well. Enormous amount of harm will be done by that. So it's not just a matter of, we got to minimize the number of deaths.
So leading on from this, should a government or a large organisation see risk slightly differently from an individual, such as me?
Risk, the individual and population approach to risk are totally different. Well, not totally different, but we really have to always keep in mind the responsibility of, say, public health doctors from the responsibility of individual clinicians talking to a patient. And it can be perfectly reasonable for public health doctors to recommend something as a policy. Everybody, offering statins to people with more than a 10% 10-year risk, offering breast screening to everybody, blah, blah, blah. And it might be equally rational for individuals to say, I'm not going to do it. I don't want that treatment. I'm going to choose not to. They're both right. And it depends on the perspective, because we know from studying public health and going right back to Jeffrey Rose's idea that the biggest impact on public health is not by picking out the real high-risk people and maybe stopping them drinking. It's by reducing the exposure of the vast mass of people at intermediate risk. So biggest impact on public health would be if everybody drank a little bit less, not if you just took the real drunks and stopped the drinking. That is not the effect. So if everyone, but the problem with that, and this is the Rose paradox, is that the very people you want to change the behaviour are the ones who don't see why they should change their behaviour, because the impact is minimal. They won't notice the benefits. You're asking them to give up something they enjoy for a benefit that they will not notice and will never notice, and it's only noticeable when it's multiplied up 10 million times.
Yeah, I guess we've kind of got perhaps two different situations here. We've got, going on from the example you had of statins, that this is kind of an individual risk for me. I might have a cardiovascular complication that could have been prevented by statins.
Yep.
But then if we move on to talking about infectious disease, as a kind of young, healthy person, I'm probably quite unlikely, even if I do get infected with COVID-19, to get severe symptoms from it. But multiply that risk up in a country from millions of travellers worldwide, and then suddenly there's a far larger risk of an epidemic within the country or a pandemic.
Yeah, well, this is the point about it is this idea of individual. Now, some health decisions we make are really individual. I mean, I think whether I take it, which I do, I take a statin, and that's my individual judgment, because basically it's only going to affect me. I mean, if I drop dead, it would affect my family. They might even be a bit upset. But, it still is really my decision. When it comes to vaccines and infectious diseases, nobody is an individual anymore. Infectious diseases, I'm thinking about measles when it comes to vaccine decisions, or COVID-19 when it comes to taking precautions. We are not individuals. We are members of society, and there's no such thing as just optimizing your individual situation. You have, I think, an absolute responsibility as a member of society to protect the people around you, particularly the vulnerable people. And that's why I really believe that people who avoid vaccinating their kids is outrageous and irresponsible, because they are endangering weaker kids who might not be able to have the vaccines because their immune system is compromised for some reason. And similarly, if young people, healthy people who are not going to be harmed by the virus, go around being irresponsible. They are endangering the lives of older people surrounding them, in particular their own family. So I think that we've almost got three intermediate stages. We've got the public health view, treating the whole country, the whole population, as in trying to optimize in terms of the general health of the whole population. The other extreme, we've got each individual working out what's best for them, and that which may not fit in at all with the public health. But with infectious diseases, the individual cannot just consider themselves. They must, I think, consider themselves as part of a bigger population, and they have that responsibility.
And how does this fit in with this inform versus persuade view of statistics? Because presumably on one hand, I could communicate numbers around COVID-19 by saying that your individual risk of getting severe symptoms is this. Or I could say your chances of passing it on to 10 people around you. Which ones do you communicate?
Oh, absolutely. Both of them. Part of the information is talking about the impact you might have for infectious diseases, is strongly saying the impact you may have on other people. This is not just a selfish idea of how to prevent yourself getting infected. This is how to help yourself getting prevented. But self-isolation, you've got it, or especially if you are ill, if you've got it, is about preventing it spreading to others. And this is, I think, is an absolute imperative that people obey this. And I think when it comes to actually the trying to prevent you endangering other people, I don't see anything wrong with persuasion there. I mean, you shouldn't be doing it, and you should be trying to be persuaded, if not forced, to do it. I get quite Stalinist on these things because I really think it's so irresponsible for some people to endanger the health of others. If they want to make their own decision that only affects them, it's very different. I wouldn't want to try to persuade anyone to do anything. There is this, did you know this idea, ethical persuasion? It's very interesting. I've always been, I don't really like persuasion, but there is this idea that's developed in medicine and other areas of ethical persuasion. In other words, when persuasion is not manipulation or coercion, it's when maybe as a doctor or as an authority, you genuinely believe that this action is in the person's best interests, but they don't necessarily want to do it. So you generally, how do you do that? How do you make that an ethical persuasion? And it's based on what I really like is about two things. First of all, still respecting the autonomy of the individuals, that they can refuse. No matter what, you respect their ability to choose. And the other thing is your own authenticity, your integrity, that you have to look inside yourself and really be sure that you are doing this on behalf of that individual for their best interests, not that you're doing it just to keep your clinic numbers up or to stop this person being a nuisance or something like that.
Yeah, and I guess this perhaps asks the question of how do we deal with the fact that maybe our perceptions of risk can change dramatically over time, or over hours or days or years or weeks.
Oh, well, I mean, humans are useless. Well, I wouldn't say useless at it because we're not. We're actually rather good at dealing with risks and uncertainties. Of course we are in our lives, and we don't put numbers on them. We constantly make small adjustments to make our lives slightly safer. We're tweaking our behaviour all the time. And people are very good at it. Their gut feelings are extremely good at this business. When we drive, when we go walk around the streets, when we but where they can become very distorted, though, is when you're in a situation with what some psychologists call fear factors. When there's sort of dread risks, when there's novel, which is virus radiation is a classic one. When people don't understand it, it's novel. Particularly if you feel it's someone else to blame, which isn't really the case so much of this virus, although you could blame Chinese markets in some extent.
Yeah, indeed. I think Nature's released a rather kind of unusual byword by one of their articles because it's been linked to biowarfare so many times in China, and actually had to say, listen, this isn't what we meant. So perhaps China's getting an unfair criticism in some cases for being the origin of this virus, where there are other things where it's perhaps got more control over it that we can be more critical of.
Yeah, possibly. Yeah, I think, but blame is one area. I mean, when you think of Fukushima and things like that, people can get, and when it's something they don't really understand or it affects vulnerable people, there's a well-known list of things that make people fearful of things. And in that sense, they can get an extremely distorted view of what's important. Their priorities and their anxieties can get the better of their brain, which is, was shown classically in the Fukushima reaction, which is, far more people have been harmed by the measures taken after Fukushima than were ever actually harmed by the radiation.
And I guess in the same way we more headlines are made by kind of acts of terrorism across Europe than car accidents.
Yes, yeah. Again, this is sort of, it's idea of outrage is extremely important. That if people feel outraged, and of course the media pump this up quite right, but people do feel outraged. This should not happen, and this takes into some overwhelms, I think, fairly reasonably in some circumstances, the actual magnitude of the risk. That people think, I don't know, terrible big train, either terrorism events, but say train crashes and things like that. They just should not happen. We live in a decent society. We should not be exposed to this kind of thing. But compared with other risks where, the seasonal flu, for example, well, people seem to just take it on the chin that this is going to happen. Some people are going to die. It varies or whatever. And so we just accept that this is part of living in society. And so we do have to respect, I think, people's feelings about these. So it's not just a matter of making us as safe as possible or maximize, counting the numbers, even counting the bodies. There are issues where people feel quite reasonably, I don't want to live in a society where these kind of things happen.
Although I guess this could be dangerous at in some occasions, because yes, it's fantastic that we should be outraged by train crashes and things like that, and whatever poor regulation leading to nuclear meltdowns.
Yeah.
But also, I feel like sometimes there can be this perception of things that government has control over and things that government doesn't have control over. And I think the opioid epidemic in America is a classic example of that, where actually it might have been seen slightly as past government's remit, which maybe convinces people that actually there isn't as much of a responsibility to deal with these big risks.
Exactly. I mean, that's a classic example, a total disaster in terms of regulation and control. Awful, vast numbers of people dying of that. I mean, even if, it's a bit easier to say, well, these people, they're weak and they're taking their, opioids for all sorts of reasons. So, this is a group of society that people would tend not to probably care too much about, which is an awful thing to say. And that might reduce the attention to the problem. But that is one where, in a way, a seriously big risk, seriously big problem is ignored, and yet other risks might have vast amounts of effort and put in. I'm thinking particularly of nuclear waste disposal. Billions spent on that. What a waste of time. I mean, really, this stuff is not dangerous. You could put it all over the place. I think you should put it in the middle of Cambridge, right in the marketplace. This is the nuclear waste store. It's absurd. There's billions spent that could be used so much more effectively to actually save lives. Whereas this isn't going to, all that money is not going to save anyone's life at all. It's just going to make some people feel happier.
I guess bringing this all together, it's the question of to what extent should we protect people from decisions they might regret in the future?
Right, well, I think, and again, it depends how much you've got to, part of medical ethics, of course, respecting people's autonomy. And this is partly where the ethical persuasion comes in. If people are determined to do things that will really, you feel, lead to their harm in the future, that's not very good. And, maybe you can't, but that's why we feel that, one of the big measures is it's quite difficult to measure the benefits or the effectiveness of the kind of thing that we want to do, empowering people to make more informed decisions. Because we can't just count how many people do X, Y, and Z, because we're not trying to change people's behaviour. We want to make sure that when people make a decision about their treatments following cancer or something like that, that they feel that they were properly informed. You can ask them that they've taken into account all the information, blah, blah, blah. But actually, what a lot of this is perhaps asking people later would like to do, did you regret how the decision was made? Did you regret? The anticipation of regret is an extremely powerful emotional idea that makes people avoid things in order to not to be regretted in the future. That's what leads to a lot of action. And therefore, it is important that we don't want regret. And one of the things that leads to regret is that people feel they've been conned or forced or pushed into doing something that actually on deeper reflection they might have realised was not appropriate for them, was not the best choice for them. And that upsets people a lot when they feel that they've been channeled into a path that if they'd really thought about it, they might not have taken.
Although I guess at the same time we should be wary of people's kind of memories of things being skewed at the
yeah.
same time. So if we're asking somebody 5 years later whether they regretted some decisions, then how do we weigh perhaps their experiences between now and then and their view of their future life, which is much more kind of salient to the moment.
It's very difficult to do. And it's one of these things that, by the time you've asked them, then everything's changed so much. And also that people, we say in healthcare, people have got quite reasonably, a rosy view. People give very high ratings because you're treated usually generally with a lot of kindness, a lot of concern. But I've been in that. I feel I've been in that position myself about that. I just feel that in the end, I can look back and say, I don't think actually I was very well. I didn't deal with that situation very well. I was in many patients when they're making decisions are in a situation of emotional turmoil. They're feeling very vulnerable. They're feeling confused, and actually that's not the right situation to be in when you're making decisions.
Yeah, and I think one other thing I wanted to touch upon was this notion of short-term and long-term risk, and how our perceptions of that can be slightly skewed as well. And I was wondering if you had any thoughts on that.
It's very. I mean, that's the way you can make people live through all sorts of paradoxes and express all sorts of paradoxes by comparing people's short-term attitudes and long-term attitudes that people will do in the short term what's clearly harmful for their long-term outcomes. And we all do that all the time in terms of our behavior. We know we should do something that will help me live longer, and we find it very difficult to do. So it's just part of being human. Is this trade-off for short-term demand, and it's very difficult to change people's, I think, perspective in terms of their what's known as executive function in order to perhaps put off a treat now in order to delay that for the future, whether it's for saving for pensions or whatever it is you're doing. And I think this is enormously just a standard human characteristic and very difficult to deal with. One of the situations where it comes into us is, for example, looking at long-term effects of chemotherapy following breast cancer or whatever like that, that you can have treatments that in the short term might be doing you good, but in the long term might do you harm. It's true for radiotherapy as well. So, we haven't really come to grips with this yet, how best to communicate this view that, this might help you. And, technically, what you can get is crossing survival curves that, in the short term, doing one thing better, but if you wait long enough, the curve actually dips, so fewer people will reach, old age. Now, that might be fine depends on your values. If you are valuing I just want the next 15 years or 10 years incredibly important, and after that, really, I don't mind. I want to see my grandchildren grow into adults or something like that. So not everybody is valuing length of life. And that, of course, comes into spectacularly in terms of quality of life. As people say, I want to add, life to years rather than years to life. I think it's a very good phrase that many people, and I count myself in here, I think, would prefer to have fewer years of better quality than live a longer time with a reduced quality of life. And in a way, allowing people to express those values and for those to be permitted in terms of the discussion, I think is incredibly valuable.
Yeah, and this comes down to the whole idea of communication being one of the most important things in this medical relationship.
And communication is not a one-way process. It's not just telling people things. That's why, again, why I say the first rule of communication is to shut up and just listen. And good doctors will do that. Of course they will. Communication is a two-way process, and good doctors will listen and explore the person's values and concerns, and also explore to what extent does that person want to be guided, want to be told what to do, and especially if, of course, the patient says, well, thank you very much for telling me. Which is a classic response, I think. Thank you very much for telling me that all those options. And now, what do you think I should do? Or what do you think you would do, or your mother, you would recommend to your mother, or something like that? And they want the guidance, and that's perfectly appropriate to want the guidance from a trusted source. Now, but that again, now you're talking about trusted source in trustworthy guidance or ethical persuasion, so, well, I think I would recommend doing that. Part of that, again, I really like this idea of respecting the autonomy of the person to not to actually not say I don't want to do that, and also to make sure that you, before going to that stage, you really have genuinely laid out the options in a way that gives it balance. You haven't tried to manipulate them by your storytelling into a particular direction. Very difficult to do, but I think it's a worthy objective. And then, having done that, it's perfectly reasonable, I think, to then give advice. It's not. I mean, I think the worst sort of medical care would be just to say, "Oh, well, it's completely up to you. I'm not going to say give any advice." Well, hang on, you're the guy who knows. You're the person who's supposed to be the expert. I want your advice. So it's not a just presenting people. Oh, it's up to you. It's not. It's total autonomy decision. So I think this is a valuable process, which I hope all medical students are being taught how to engage. It's not paternalism. Paternalism is just immediately saying you should do this. I think you should do this, without even really allowing that person a full autonomy to choose.
Yeah. Yes, part of a kind of evidence-based approach to it. And I know that you've been developing, I think, the Predict Breast Cancer online tools to help clinicians really understand what particular risks are. Because there's some evidence coming out actually across kind of all specialties that doctors aren't necessarily as good at judging precise risks in decisions such as this as we might expect them to be.
No, I mean, a good algorithm, again and again, it's been shown a good algorithm will tend to beat when you're putting together complex information, in terms of its accuracy of predicting what's going to happen, will beat any doctor pretty well. And that's why, say, our Predict system, which was developed in Cambridge, the algorithm, we didn't develop the algorithm, we're putting the front end on, is used enormously by clinical teams in multidisciplinary team meetings, because it's good, a good reliable voice in the room that will reliably and unemotionally would just say, well, this is what we think the survival rate would be in patients like this. And then, of course, you can add in the individual perspectives that only the humans know, because the algorithm can only take in certain bits of information. It's a stupid thing. It really is. It's a dim-witted thing. It just puts it through a formula and out comes a graph or a number. So it doesn't know that this patient is very frail, for example. It doesn't know all sorts of things about them, and so or what the patient's values are, what it's concerned with, and so all those then have to be put on top of this basic advice. But I think that combination of the algorithm doing what it's best at, which is essentially systematically summarizing tens of thousands of cases in vast amounts of history, but it still is not personalized. It's stratified medicine, which I like the difference. Personalized medicine, no algorithm is going to be able to do that, because it can never identify all the important characteristics. Stratified medicine, in other words, that it's how I put that person into a particular group in which it's got some good data, and it can say, out of 100 people in this group, this is what we would expect to happen to them. But within that group, people are still going to vary a lot, and that has to also be taken into account.
So with all these kind of new tools being developed, how skilled do you think clinicians should have to be with statistics, which can get fantastically complicated?
They doesn't have to get in fantastically complicated statistics. I mean, some areas are, and that's fine if people are interested in that. You don't need it. It's all just to do with proportions. That's all. It's not a skill. Well, it is a skill. It is a skill in how to tell the story, because and there's been a lot of work on this, and I think clinicians now, we've got some online courses that do this, I think can learn to do it pretty well. That getting an rough idea of magnitudes is very important. And I think to avoid words like chances, and even I'm not that keen on percentages. I'd much rather say, well, our experience shows that out of 100 people who match you in these characteristics, who are like, they're not you, but 100 people matching, this is what we'd expect to happen. About 60 of them would survive this, and 50 of them, blah, blah, 30 of them, blah, blah, blah. Just, as a description, you draw a little picture and things like that. So we've got these possibilities. They're not all equally likely. Some of them, but we don't know. For you could be, essentially you could be lucky or unlucky. Whether you want to use those words is another matter. But, we don't know which one of these you'll be. And then I think it's very reasonable to tune it. But in your circumstances, we actually think you're a better. Other factors mean you're slightly better. So we'd put your chances of something better go a little bit higher than that. But we can't guarantee it either way. And I think that's being very fair. We can't tell you what's going to happen to them. We developed this. We spent ages when we were working on something for child heart surgery, which is such a delicate area, trying to find the wording for what we statisticians would call random error or binomial variability, that you can give a percentage, 80%, 95% survival rate. Well, am I going to be one of the 5% or 95%? Well, I don't know. It's just chance or luck, fortune. We can't really use those words in such delicate situations, operating on children. So we spent ages trying to use the word about why we cannot predict who's going to be in the 5 and who's going to be in the 95. And then we came up with a good phrase, or somebody we talked to, which we used and tested on parents, and I think it's very good. It's unforeseeable factors. Not unforeseen factors, because that would suggest someone's to blame, but the unforeseeable factors could lead some people to essentially not survive the operation and some to survive. So, in other words, we can put you in a group, but we can't go beyond that, and only what develops over time, in terms of complications or something like that, could end up you in one group or another. Unforeseeable factors. I really like that phrase. I try to use it all the time and recommend it.
Yeah, and I guess part of the future of medicine is perhaps trying to make some of those unforeseeable factors actually predictable.
Oh, yes, yeah. No, the whole thing is to try to hone that right down, to try to personalise things and to get rid of some of those by better prevention, and that the numbers move. I mean, I've worked in child heart surgery for more than 20, 30 years, and so it's staggering where, mortality rates have gone from, 13% or something down to 2%. Unbelievable survival rates now, 98% survival rates in child heart surgery, which are extraordinary. These are like adult cardiac surgery, staggering achievements. But they're always trying to, as you said, make some of those factors that led to these deaths in the future more avoidable.
I noticed you use the absolute risk values there rather than relative ones.
Relative risks are disastrous. You should never. Relative risks are deeply misleading. They're a manipulative form of communication. To ever say, "Oh, this doubles your risk," or "this increases your risk to 50%," absolute no. They are hopeless. In some situations, they can be very valuable, but I'll come on to that. But in general medical things, it's outrageous. What you should be always giving you is what the absolute risks are, with and without something. So, if you have this. I don't know, like me, my statins, people like me, I was getting, with my risk factors, I was getting something like, 15% 10-year risk. 15 out of 100 people like me might expect to have a heart attack or stroke. So I take statins, and my LDL went down by 2 millimoles. I reckon it cut it by, roughly halved it. And I think that's, really valuable thing. I'll never know whether it's actually benefited on me, not me taking this tablet every day, but it's only in terms of relative risks that it's gone from 15% to 7 or 8%, and that's the fact. Although actually being told it halves it does sound good, but if it wasn't a very big number in the first place, halving it is of no interest.
Yeah, it could halve from 1 in 10,000 to 1 in 20,000.
Yeah, which is boring, especially if the thing's going to give me some side effect. I don't seem to get side effects, but if I did, it'd be completely pointless me having this. So you cannot know whether you should do something. In other words, you cannot trade off the benefits of the harms from a medical treatment without knowing the absolute risks. You cannot do it in any rational way whatsoever.
Because these absolute risks allow comparison between the benefits and harms if you translate them.
Exactly. You must have that. Otherwise, it is a really manipulative form. And people realise it. Trying to do better in doing that. A lot of the communication now is using absolute risk, which is a huge improvement.
But then at the same time, you said there might be some advantages to using
absolute relative risks are very valuable in what you might call low probability, high impact events. Every time you cross the road, there is a low probability and high impact that you're going to get run over, and that you don't want to do that. But so what you do is constantly you take extra precautions to reduce what is a very small risk to one that's even smaller. And if you measure that on an absolute risk scale, you say, I'm not going to bother to do that. It's not worth doing it. It would look like that. But actually, just by making that low risk even smaller, it's a really valid thing to do. And people discovered this when they were doing earthquake predictions on people, by telling people the absolute risk of an earthquake. It could be deeply, because it's always low. They're very unpredictable. And so the absolute risk is always low. But telling people it's 10 times normal or 100 times normal, people will act, and quite appropriately. And others, they won't panic, they won't rush away, I think. But in Italy, for example, they go and sleep outside for a bit. They get out of the house. So they might take small actions in order to make what is a low risk even smaller. So in certain circumstances, a relative risk can be very valuable to give. So I would say actually using both in those situations of very small risks and where the consequences are really severe.
So perhaps could we say that it's as well justifiable to use relative risks when actually the consequences of acting upon something aren't that great? Sleeping outside, for example, or looking
exactly.
across the road.
Where the cost of the intervention, the action, is actually minimal. Taking a bit more precautions, being a bit more careful. So you're doing actually not putting a big investment into something that makes a very small risk even smaller. And so you can keep on doing that. You just constantly just avoiding, not walking under ladders, it's very unlikely anything would happen, but you're just doing a low cost change in your behavior to make a small risk even smaller. And absolute risks don't really deal well with that. So because you're talking about 0.000, it's very difficult to deal with those ideas.
Although it's interesting that we seem to consistently overestimate very low risks and underestimate very high risks.
But that's a general measurement problem. We find it very difficult to deal with numbers. Low numbers, million, 1 in a million, 1 in a billion. What's the difference? I can't cope. Once I have to start counting the zeros, all feeling and intuition goes. So it's hopeless, actually. And of course we're bad at it. Why should we be good at doing that sort of thing?
And do you think more standardization here is a good thing? Because, even reading through the news or scientific papers, there are lots of different ways of communicating quite similar statistics.
Yeah, and it's getting better, I think, because there are getting expected patterns to do it. As I said, it's more and more reported that people will use what's called this expected frequency format, where instead of talking about 0.00 or 0.03 per person year, or so, God, what does that mean, for heaven's sakes? Absolutely ridiculous scientific language for something. No, what you say is, out of 100 people or 1,000 people, we would expect 3 for this to happen each year, or something like that. You talk about a specific group of people, which you can even draw a little picture of and show what's happening. And that is it helps enormously. You want to bring things to whole numbers, small numbers, preferably between 1 and 100, or 1 and 50 even, because that's the sort of magnitudes that people have got a feeling for. You don't want to be using no decimal places, no multiple zeros. You've got to get rid of all of that. You've got to get things to units that people can understand, preferably on a scale 1 to 10.
And I guess we bring this all together to call it framing.
Yeah. Framing's absolutely vital. So all the work in communication is driven by the work of psychologists, people like Kahneman, Tversky, and things like that. So, the simplest one, of course, is not always to talk about mortality rates, but to talk about survival rates, and preferably, though, to give both. Our predict systems are almost all, everything in them is positively framed. It's all in terms of survival. So we draw survival curves, not mortality curves, although a lot of stuff in the scientific literature would be cumulative incidence of conditions. No, we do survival curves. In other words, how long can you be without this condition?
And what's the rationale for that then?
Well, we know that positive. In a way, you should give both, but we know that it makes a big difference to people's impact whether you talk about 2% mortality or 98% survival. So, the two things. One, the 2% mortality sounds rather terrifying. The 98% survival sounds rather good. And we don't want to unnecessarily upset people about their future prospects. We are all going to die, for heaven's sake. So it's 100% mortality in the end. But you want to show a decline in survival. I think because it's just fairer and more likely to get people engaged rather than frightening them off immediately. But we found that when we finally provide an icon array that shows everybody and it shows the deaths, and patients like it. They go for it. They like saying, out of 100 people like me, this is in 10 years' time, how many people are going to be alive because they had their chemotherapy, or dead because of breast cancer, or dead because of another reason. And they like it. What they didn't like, quite reasonably, was where we had the deaths from other causes as great big sort of black people, really lurid, they really stood out. That was not appropriate. So we now no longer use little pictures of people. We use dots, and we don't fill in the deaths. We don't make the eye, we don't draw the eye so much to these deaths from other causes, which after all is just due to age. It's inevitable that people are going to die of something. And there's no point in drawing undue attention to things that are not so massively relevant to the decision.
Yeah, because I was going to say, to play devil's advocate slightly, there's a difference between patients liking how you've presented something and actually patients finding it useful in their decision making.
Yeah, and we try to, of course, measure all three. We measure, basically it's all the time. It's the cognitive, the affective, and the behavioural impact. So the cognitive, do they understand it? So you can ask them questions about it all the time. The affective or emotional is how do they feel about it? Do they like it? Does it upset them? Does it, whatever? What is their emotional response to it? And the behavioural one is how does it change your intention? Maybe change your behaviour, but we don't look that far. How does it change your intention? Could this influence what decision you want to do? Not that we want to make them do one thing or another, but we would be happy for it to influence their decision. We just don't want to push them in one direction or another. And you can check all those things. It's really valuable, really. And of course, they can mean you can understand something and not be influenced by it. You can like something and not understand it. So these three aspects are almost sort of orthogonal. They really, because you love the idea of someone. It's so clear that they understand it. They say, oh yes, now I feel so happy about this, and therefore I'll do X. That little linear path does not what really happens.
Yeah, and I guess it happens even less when we're moving out of a clinic where perhaps there's kind of one source of information or one kind of entity, the doctor, through which information is being funneled into the world of mass media and social media, where actually different articles and headlines are competing with hundreds of other ones, which people might like or dislike.
Yeah. Everybody who's been a patient knows who everybody is, really. You start clicking around and you find so many diverse sources of information. And that's why the idea of trustworthiness is incredibly important in terms of sources. I mean, I recommend NHS Choices, Cancer Research UK, and I feel these are trustworthy sources for good information, and some of the big charities as well. So, and you need to look, because you'll always find different information given everywhere. And that's why, actually, in the end, although not everyone likes numbers, we do want to try to provide some statistics, some numbers, some idea of magnitude. So then you can say, well, and this is the evidence behind it, and this is what we feel actually are the magnitudes, instead of unduly trying to make people anxious or unduly trying to reassure people.
Yeah, and I guess a question leading on from this is, are people who really do have expertise in this going to the right places to communicate their ideas? So doctors and scientists write in papers, they go to conferences. I know you've got your podcast, Risky Talks, but we don't see much on Instagram or BuzzFeed, for example.
That's them. Very interesting, because you're right. People who, there should be more people who got good communicators, got expertise interacting on things. I know that some people do go onto Mumsnet and go on to other discussion groups. I think the patient discussion support group on the online patient support is one of the most wonderful thing that's happened in medicine, especially with people with rare conditions, because patients are experts, and I think those are enormously beneficial. And of course, you get expert patients who then give advice and give good sources and things like that. And I think outside professionals, they got a role in providing some information with due humility, because in the end, this is not their platform. I think that we should be thinking a lot more about the channels by which people communicate good, reliable numbers. As I said, we still tend to do it through our formal platforms that we've established, NHS approved and this sort of thing, which is, of course, is very good to get the brand. That's why all our work we want to get on NHS branded websites, because it's terribly important, because this is a demonstration of trustworthiness, and we want to take advantage of that, because otherwise how do you discriminate us from anybody else? So I think it is tricky just to get in there in the morass of social media where you're just one voice among all the others.
Yeah, I guess when I look at the NHS website or NICE's website, I kind of associate all, or certainly the vast majority of the information on there as trustworthy. Whereas if you were to go onto I don't know, other where you mentioned kind of Mumsnet or social media pages, actually it might be much more dependent on the individual who's writing
exactly.
it.
So you'd have to, in a way, when you give your opinion, you might feel, oh, my opinion's better than other opinion, but what are you supposed to do? Put all your academic qualifications down the bottom or whatever? So I think it is tricky, because in the end, once you're on there, you are the same as everyone. You're just one voice among many. And as anyone who's read, done some journalism or been mentioned in articles in The Guardian or whatever, and you start reading the comments and you think, do I really want to get involved in this fray? I mean, really, do I really want to engage with this? And there's a big disincentive to actually engage with. Some people do. I mean, I've been so impressed by some people who work in the climate change world who are really willing to engage with people on with critics on social media, and I deeply respect that. I couldn't face it.
Yeah, I guess it must be quite difficult, particularly when you're not entirely sure whether your message is even going to get across.
Yeah, well, or just be rubbished and or be greeted with abuse. That's really tough to take, and not one I'm prepared to take.
Yeah, and we've had a slight amount of Twitter abuse, but luckily not so much yet.
Yeah. I mean, I don't get that too much at all, because I think I'm very cautious. I've got a lot of Twitter followers, but I'm very cautious about what I say, and do really word each message carefully to try to understate and not to. And certainly not to be aggressive, but when I don't like being I don't think anyone likes being criticised. I don't like it, even if I think it's really unjustified. And I must say, my immediate emotional reaction is extremely childish. I have an urge to lash out with abusive replies, and I have to sort of grip it. No. And I've been trying to respond positively with kindness and respect. And it works. I think it does, not with everybody. It's people you just have to block, I think. But it can work if you're prepared to put the effort into it. I think the biggest, kindness and politeness and respect are the qualities, I think, to which there will be a huge amount more attention paid to them in the future. There already is, because people have seen the awfulness of discourse, which collapses into abuse and disrespect.
Yeah, I certainly agree going into the future. So hopefully it'll be words that everyone can kind of take into their lives. Yeah. So Professor Spiegelhalter, thanks so much for joining me.
Oh, it's been a pleasure. Thanks very much.
It's been fantastic.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.